Good afternoon, and welcome to Psychiatry Grand Rounds. There is no commercial support for today's program. The planners have disclosed no relevant financial relationships with commercial interests. Our speaker will announce his disclosure. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you have a question, please enter it into the Q&A chat if you're viewing online. A link to the event evaluation will be given to you at the end of the program. It is my pleasure now to introduce our guest speaker, Dr. Suneel Katragadda. Dr. Katragadda went to medical school in India and completed graduate school at Eastern Michigan University, followed by a psychiatry residency and child and adolescent fellowship at University of Alabama at Birmingham. He then served as medical director of Avita Community Partners for 2 years. He has been working as medical director at Peachford Behavioral Health System for the last 15 years. He is active in private practice as well as clinical research in children, adolescents, and adults. Join me in welcoming Dr. Katragadda.
Thank you so much for such a kind introduction. All right, so hope everybody settled down. So today we're going to talk about a topic is kind of a little interesting, right? Review of novel drugs in psychiatry. This is a kind of a whirlwind tour, or fast-paced, high-speed tour of psychopharmacology in entirety. We're talking about from beginnings, humble beginnings of psychopharmacology in 1950s to where we are, and we're going to kind of touch base on high points of psychopharmacology, what we experienced, how we get to where we are now. So just bear with me. So I'm going to give a little bit of introduction before we start. Like Jennifer said, I've been here for almost 20 years in Atlanta, and 16 years I've been there at Peachford Hospital. I've been working in both clinical and the research side. And these are my disclosures as a speaker for those companies, and also getting research grants from a variety of companies and different clinical trials. All right, so today I'm going to give a little outline. So first we're going to talk about just the biogenic amines. You know, somebody was just asking, what does biogenic amine means? Basically, it's the word that's used to describe 3 commonly known neurotransmitters: serotonin, norepinephrine, and dopamine. There is a 4th one called histamine. It's not so much relevant for psychiatry field. So all those 3 of them structurally similar and kind of convert from each other just with one enzymatic step. So they're all combined as biogenic amines. And this has a lot of history about biogenic amines. So I'm going to walk you through it a little bit. And then we have FDA-approved drugs targeting different biogenic amines in treating different psychiatric disorders. And then we can talk about a lot of paradigm shifts in understanding pathogenesis of different mental health conditions, and also the targets we use to treat those conditions. And I'm going to take you into the a little bit of a research side to see what is out there, what are the new compounds that may be coming soon, or maybe next year or 2 hitting the market. So see how the trends are, what are we really looking at in most recent clinical research areas. And then we're going to talk about how we reach to where we are in targeting biogenic amines. Interestingly, we started out with the biogenic amines. Let me take you a little bit back in the history, even though I don't have slides for that, but I'll tell you. Let's see. We are in 2025. So if you were a treating physician at 1940s, there were not really any psychiatric drugs to treat any conditions. What were we doing? How were we treating those conditions was what the psychotherapy, psychoanalysis, psychosocial interventions, And even worse, we're doing a bleeding, literally bleeding, venesection, cutting out, bleeding people out to help them, and even the purging and making them purge and making them do sleep deprived. And even worse, we were doing psychosurgeries in 1940s to 60s. You know what psychosurgeries means? Basically disconnecting one part of the brain to the other. So typically leucotomies were disconnecting prefrontal cortex from the frontal lobes in an attempt to treat psychosis or schizophrenia, what we know now. So even though it wasn't very successful, that wasn't a practice for 20, 30 years until 60s. Finally, we abandoned it, thank God, right? So even to our horror, 1949, Nobel Prize was given to physiology and medicine to the pioneer of psychosurgery, Antonio Moniz. So see where we were. That's where we were in the 1940s. And the first drug that was introduced into psychiatry field was chlorpromazine or thorazine. That was 1954. And then we have iproniazid, which was the MAO inhibitor, first time introduced in 58. So what those two drugs did for us was they raised the awareness to look at biological underpinnings, not just the psychological or psychosocial aspects of mental health. So that started all the research in understanding the neurobiology of different mental illnesses. That's how we invented neurotransmitters, neuroreceptors, how the drugs bind to the receptors. Then we got into the clinical trials, how to test the drugs in a randomized placebo-controlled way without any doubt that we can convince people that these are truly effective and safe to take. That's where we started. And I'll show you one picture. This tells you all. I don't know if anybody saw this on Google. This is a picture from Seaview Hospital in New York, the patients dancing. These patients are not just patients. This was a TB asylum in New York. When they're testing a drug called iproniazid for TB, a lot of these tuberculosis patients were suddenly kind of in a matter of weeks were jumping with the joy. So then everybody scratched their head. What the heck? These patients were supposed to be terribly depressed or terminally ill, or they are kind of almost in a hospice care, and everybody seemed to be so happy. And then they looked at the drug, iproniazid, and they found out that was actually a MAO inhibitor. So that was increasing the biogenic amines, like a serotonin, norepinephrine, dopamine. That's how that's making happy. That triggered further research into looking into depression. And then that drug was the first drug approved as an antidepressant in 1958. So that's where we started, even though it was pulled from the market 3 years later for hepatotoxicity and hypertensive crisis, but that paved the way for developing other antidepressants. This was the headline news that time after the, say, terminally ill tuberculosis patients dancing at Old Seaview Hospital, New York, after TB trials using iproniazid. It was found to be MAO inhibitors. That was presented at an APA meeting that year. All right, so now coming down to biogenic amines. Why biogenic amines? This was one of the examples how we got curious and interested in wanting to learn more about biogenic amines. So we didn't have a concept of somebody having a serotonin deficiency or norepinephrine deficiency before all this. At the same time around, historically, there was a drug called reserpine that was introduced into the market as an antipsychotic. Believe it or not, before 1950s, a lot of psychoactive compounds were available as a herbal products. For example, in Chinese medicine, Indian medicine, a lot of these herbal products were used for centuries, even though modern psychopharmacology started after chlorpromazine and iproniazid. But before that, for example, there was a herbal product called Rauwolfia serpentina from Indian snake root. That was a reserpine, was a compound that came from that, the alkaloid. That was used thousands and thousands of years ago for snake bites and to treat insanity in India. So there was that the same reserpine that was introduced in 1950s, an antipsychotic. What happened was once they started using it, they were all having depletion of the monoamines, and people were starting kind of looking like depressed. But we thought they were depressed. But that generated the curiosity. Yay, we gave this depleted biogenic amines. That means these people getting depressed when you deplete these. So then we're going to have to go look at it, and so why the depression happens. Maybe possibly because they have inherent chemical imbalance, not having adequate activity of serotonin and norepinephrine. But it turned out to be a false over the time because we were not able to replicate by giving reserpine. We were not able to make anybody depressed. But it did help with the science because we started looking. The train already left. So we already started the research with the reserpine experience and also with the iproniazid experience. And then that's where the biogenic amine theory started, where people who have a depression, maybe inadequate activity of any of those neurotransmitters, schizophrenia, people having maybe decreased activity of dopamine in the frontal lobes or increased activity in the limbic system. So all that stuff started because we started focusing all on biogenic amines. And then, as you know, if you are a resident or if you are a provider, pretty much most of the psychiatric conditions have some sort of dysregulation of biogenic amines was proposed. Anxiety, for example, same, serotonin, norepinephrine. PTSD, the same. ADHD, the dopamine dysregulation. Substance use, it's a dopamine is a modulator in having people addicted to the different substances. So see, our world was revolving around biogenic amines. Believe it or not, we were living in the biogenic amines for over 60 years, from 1950s to all the way to 2018, 2019. We're still chasing all biogenic amines as a targets to treat all these conditions. So if you want to look at it, the timeline of the historically, I don't expect you to remember, but here you can see it started out iproniazid in 1958. There you go. There it is. So after that, tricyclic antidepressants, a lot of Me Too tricyclic antidepressants came after imipramine, and then bupropion came in, then the Prozac. The letters I highlighted in red because those are kind of important milestones in psychopharmacology. And the Prozac was the pioneer, right? The very first SSRI that came to market in '87. You can see all other SSRI type of medications followed. And the last one that came out was vortioxetine in 2013. And then SNRIs, venlafaxine, basically the neurotransmitter norepinephrine has also targeted along with the serotonin. The attempt was made to enhance both at the same time. That's the concept of SNRI, or serotonin norepinephrine reuptake inhibitors. Then we have a very important conceptual change when we try to use augmentation agents, especially antipsychotic medications, starting with aripiprazole. That's very important landmark for us. And then we have in 2019, even bigger landmark was using ketamine. I'll walk you through how we got to the ketamine in a short while. And then we have the most recent one was dextromethorphan. Yes, you heard it right. That is a cough suppressant. That was approved antidepressant as well. That was the most recent in 2022. There were a lot of differences mechanistically after SSRIs here. All these are biogenic amines, right? All these are biogenic amines as targets. All SNRIs are the same way. Even the antipsychotics are targeting biogenic amines, right? Except the ones that came out in 2019 and 2022, they're targeting another neurotransmitter called glutamate. So that is the fundamental shift in understanding depression in a different way. And there was always a need to understand the differently other than just biogenic amine theory, because biogenic amine theory is not 100% perfect, but we didn't have much of a choice because we didn't have tools, we didn't have any other chemicals, we didn't have any other ways to prove other mechanisms of either depression or schizophrenia. So we'll either want it or not, we're stuck with biogenic amine theory for over 50 or 60 years. So there were some, I want to walk you through some of the more recent medications that kind of work differently than a typical SSRI or a serotonin reuptake inhibitor or a norepinephrine reuptake inhibitor. So these may be not as popular, they're not probably as familiar, but I think it's helped us understand in targeting of different neurotransmitters in treating mental health conditions. And this was a very important concept in 2019, fundamental shift of using, instead of SSRIs or SNRIs, using a neuroactive steroids. This is basically a progesterone analog, very first one that's released to the market in 2019. It's called brexanolone or Zulresso. This was approved for postpartum depression. So people didn't have any specific antidepressant target for postpartum onset of major depressive disorder until we have very first indication, which is a brexanolone. Even though it was not ideal, people needed 60 hours of IV transfusion, hospitalization, so it didn't take off because of logistics, because of the expense and the price. But nevertheless, it helped us understanding. So if you notice, it doesn't work through the biogenic amines. It's a GABA modulator. GABA is a gamma-aminobutyric acid, is another neurotransmitter that is a predominant inhibitory type of neurotransmitter in the brain. So it modulates GABA, thereby possibly stabilizing stress response from HPA axis. HPA is a hypothalamo-pituitary-adrenal axis where people have a stress response. That's the theory that's proposed, how these neurosteroids work. And then there was improvised neurosteroid that came out later. It's called zuranolone, which is similar to brexanolone, but it's oral. It can be given for 2-week treatment. So there were very important concept changes, right? So this is the first time we kind of went outside biogenic amines. There may be other ways to kind of help the depression. So we're still kind of talking about depression. So, and other thing that came out in the market is ketamine analogs. So if you see ketamine or Spravato in a brand name, it's approved in 2019 as a antidepressant to use with antidepressants. So somebody who didn't respond to at least 2 antidepressants, they can take a third new antidepressant and then combine with the ketamine. So that was a very important step. That's the first time we had a medicine that's approved for treatment-resistant depression and the depression with suicidal thoughts. And then followed by dextromethorphan, which is a cough suppressant. It also works on NMDA or glutamate receptor. Specific subtype is the NMDA receptor. Both are antidepressants. The difference is dextromethorphan is approved for a monotherapy as opposed to combination treatment for ketamine. So that's interesting. See how we are kind of moving along. So away from the biogenic amines and then using as a combination, then using as a monotherapy as well. So I'll see you some striking data to see how they work different compared to our traditional SSRIs and SNRIs. And there was another medicine that came out recently in 2023. It's called Zepiron, which is 5-HT1A agonist, very similar to buspirone if you're familiar with. So that has some specific benefits or pros and cons. I will talk to you just in a minute. So just in a little more detail on the brexanolone, it's a 2019 approval, GABA modulator for how you administer is a 60-hour infusion as an IV. And it's supposed to stabilize the HPA axis or reset the stress response or normalize it. But it's a very interesting concept of the progesterone analog as an approved drug for depression treatment. Zepiron, like I said, it has a lot of complex history of development. Over 13 trials happened. Most of them failed, but except 2 trials. That's all you need for FDA approval. Have to have 2 good trials. So they got approved in 2023 for major depressive disorder as a monotherapy again, right? So interestingly, they went back and forth. Everybody thought they abandoned the trial for a while, and then FDA called them to reopen it, and then they started a trial again, and then started it. So at least stalled 2 or 3 times. Finally, they were able to get it out of the gate, and it's in the market in 23. But it still is a biogenic amine, right? It's a 5-HT is a serotonin, right? It's a serotonin agonist, which is still targeting biogenic amine. Now, so we know now that there is another way. There are other ways to treat depression. And that's when we looked at the glutamate. And the glutamate had been a kind of a hard one to crack for a very long time. People were interested in looking at glutamate as a target for decades, but they abandoned it because it was a very difficult neurotransmitter to study and very difficult to find the right drug to actually show the difference. It's better than placebo. So that's why we have several NMDA antagonists failed in clinical trials because it was hard neurotransmitter. So I'll tell you a little bit of introduction on the glutamate, so then we'll talk about the drugs. Glutamate is a little different than other neurotransmitters like serotonin, norepinephrine, and the dopamine. They were all in the select areas of the brain along the brainstem and the prefrontal cortex and probably the front lobes a little bit to the connections from the prefrontal cortex, but not in the rest of the brain. Whereas a glutamate is a diffuse neurotransmitter. That means it's pretty much in every part of the brain. It almost covers 60% of the total amount of neurotransmitters in the brain. This is a predominant neurotransmitter. And also it is an excitatory neurotransmitter, unlike other ones. So that means if you activate this neurotransmitter, so that means it will excite the cell. That means that will get activated and the neuronal signal will propagate from the one neuron to the other. And other differences are, this is also amino acid. Glutamine is the amino acid. Glutamine, glutamate, they convert to each other from the supportive tissues to the neurons, so that way it gets transported between them. And it regulates memory, learning, and mood. So those are the 3 important things for us as a psychiatry. And not only that, glutamate is not just a chemical for a neuronal signal from one neuron to the other. It is also an important food source for the neurons in the brain. It doesn't get through the blood-brain barrier, so whatever glutamate you have outside is stay outside. It won't get into the brain. Your brain has to make its own glutamate inside. So if your glutamate goes too much, then it will destroy the cell because it activates the catabolic pathways. That's how all the autoimmune diseases like ALS, Parkinson's, multiple sclerosis, even somebody has brain injury, all those things are mediated by excessive glutamate, or what we call it, glutamate toxicity. So the glutamate is a needed, essential nutrient, and also at the same time, it helps with the recycling the cells. Essentially, the cells die at some point, and that has to be recycled. All the internal components have to be reused. So for that, glutamate is essential. But it can go rogue, and autoimmune diseases, head injuries, stroke, all those conditions, and can destroy normal tissues, so from the glutamate toxicity. So it's very much a double-edged sword. It can help you tremendously when you know how to use it. But if you don't know how to use it, it can totally destroy it. That's why you cannot easily study like serotonin or norepinephrine or dopamine. And NMDA, which is one of the receptors. By the way, glutamate has several receptors. The 2 ionotropic receptors, one is NMDA, other one is AMPA. And there are several metabotropic receptors as well. Most of the psychiatrists and psychiatric illnesses, our target is NMDA because that's the one we studied all this time. So it's important that we came back to ketamine in about 15, 20 years ago. We gave up ketamine, we left it as an antipsychotic. And then we came back to it, and we looked at it with more technology, more advancement in science 30, 40 years later. And then we were successful in demonstrating either IV infusion of ketamine or nasal spray of ketamine being very effective in treating depressive symptoms, unlike any other oral antidepressants. Not only that, it was treating people who were typically not responding to the oral antidepressants. And also they're keeping them in a remission for longer periods. So we did master it over the time. Initially it was improvement in 24 hours, and then before you give the infusion, people were relapsing and feeling depressed again, and the effect was lasting only for a week. And then we figured out how frequently we have to use it to maintain the effect, right? So we figured out with the S-ketamine, which was approved in 2019 as an augmentation for MDD, as a twice-a-week dosing would do it. So that would maintain. After doing it for 4 to 6 weeks, you can actually drop it to once a week and still can maintain the effect. And another 4 to 6 weeks, you can give only once every 2 weeks and still can maintain the effect. So we learned all that over the last 10 years, right? So as you know, S-ketamine is approved in 2019 for augmentation, and then 2020 for MDD with suicidal thoughts. And I had to update slides because it had a new approval just 2 days ago on Tuesday as a monotherapy. Think about it. So people don't even need to use antidepressant. Of course, you have to use your judgment who needs augmentation versus who needs monotherapy, but it's FDA approved. And it's a fundamental shift for the FDA also, because they debated quite a bit, because that is the complete paradigm shift, right? So if we use antidepressant, we always give every day. That's our concept for 70 years. Did we ever imagine that we could give an antidepressant 2 times in a month and you can maintain the remission? That is they did not agree. A lot of advisors in the FDA board did not agree. So that's why they debated and debated. So, but the data is staring. When we did I was a part of the monotherapy trial using Spravato, and the data was so obvious, so even FDA panel can't ignore it. So they called the company to come and get the approval. So it was that dramatic. So there was approved just Tuesday for monotherapy. I think few things to remember how ketamine or S-ketamine worked compared to oral antidepressants. But we were able to show the difference in 24 hours, the separation from the placebo. And we were able to maintain the remission for longer periods. And we were able to have a lot more people remit. You know, there is a difference between remission versus response versus no response, right? In a research world, even in clinical world, if somebody has at least 50% improvement in symptoms, that's called response. If somebody didn't even have 50%, that's not response. If somebody has scores so low on MADRS is the instrument they use to measure the severity of depression. If the score is 12 or less, that's considered remission. So a lot more people remitted in all S-ketamine and ketamine trials compared to any other oral antidepressant trials. So that's why it's dramatic, and that's why it's a fundamental shift for us in understanding that what we have at our hands, even though it didn't take off as expected because of other logistics that needed to give it, right? This medicine is under REMS program, which means risk evaluation mitigation strategy, where patients had to come to the doctor's office, stay there for 2 hours, and somebody has to drive home. So there is a lot of requirements for somebody to get ketamine or S-ketamine. So that keeps access away from a lot of people. But efficacy-wise, it's definitely well convincing, right? So if you look at the data. This is how the proposed mechanism was for ketamine or S-ketamine. Of course, the same concept applies. If you look at the presynaptic neuron and the postsynaptic neuron, and this is the interneuron. So interneuron is a inhibitory type of neuron that uses a GABA as a neurotransmitter. So here it is the glutamate that's coming from the presynaptic to synapse and the binding to the NMDA receptors. And here it is the AMPA receptor, another ionotropic receptor here. So the mechanism is supposed to be is when you give ketamine or S-ketamine, it comes down here and blocks NMDA receptors in interneuron. So interneuron is the one that keeps the control all the time. It's like your car, you kind of keep it in a brake. So what your ketamine is doing is letting the foot off the brake just for a fraction of a second. That's enough to stimulate the glutamate release because glutamate release is completely controlled at default by GABA. So once you foot off the brake, you disinhibit the inhibitory neuron, so you disinhibit the glutamate release and into the postsynaptic, and that starts the cascade of events, stimulating AMPA going up, and then you have a series of intracellular steps that happen, protein kinases. One important thing we found out was it will stimulate the production of a neurotropic factor called BDNF. That stands for brain-derived neurotropic factor. That's one of the two neurotropic factors. The other one is vascular endothelial neurotropic factor. These two are the neurotropic factors we know for sure are essential for well-being of all neurons. So by increasing the BDNF, it causes several changes in the neuronal synapses. One is increasing the production of proteins. Proteins means here we're talking about synaptic proteins. That means creating new synapses, new connections. And not only that, it's also enhancing the activity of the neurons they already have. And so neurons can communicate better with other neurons. That's called neuroplasticity. That means they are more plastic than usual. So the increased neurogenesis, that means production of new neurons, or new dendritic spikes, and increasing the neuroplasticity. That means they are more communicative with other neurons. Those are the two important mechanisms we understood, and we demonstrated in imaging studies in a matter of a day or two after infusion that you could see the dendritic spikes coming out, and you could see that the BDNF was measured and going up. And as soon as the effects, maybe 4 or 5 days later, all that's going down and the sprouts are all coming down. So when you give the repeat infusions, repeat doses, those new connections and those newly built synapses, they're staying in. So you're basically opening up the new neuronal connections, right? So have you ever wondered when you're using SSRIs, SNRIs, why we tell patients all the time, so wait for 4 to 6 weeks? I know sometimes smart patients ask, why 4 to 6 weeks? Does it take that long to go to the brain? I don't think so. All the things you take, it goes to the brain, show up in a matter of a few hours. But there is a significant lag time, right? When you use SSRIs and SNRIs, they're not effective. So you have to educate patients to hang in there and keep taking it, and you will see the difference possibly in a few weeks or 4 to 6 weeks. And there were a lot of theories were proposed to see why the lag time was. But even though there is no one significant universally accepted theory, but one of the theories proposed was that maybe serotonin reuptake, norepinephrine reuptake, these things take time to stick. That means even though you're trying to do the reuptake inhibition, there is a counter mechanisms that are blocking it at the presynaptic level. So the balance finally tilts towards upregulation of the receptors, increased activity of serotonin. That process takes 4 to 6 years. That's one theory. Another theory is totally after the ketamine and the S-ketamine, the whole biogenic amine theory was revamped. And a lot of people are proposing a theory where depression may be not from deficiency of these chemicals, but maybe because deficiency of BDNF. So because it's a neurotropic factor, if you don't have enough, you get the atrophy in the prefrontal cortex and possibly causing the depression because your neurons are dying like any other degenerative disease. So when you use the medicine like ketamine, you're increasing the BDNF, and then you're reversing some of that loss. And you are showing that in imaging studies. Even with serotonin reuptake, norepinephrine reuptake, ultimately they're increasing the BDNF levels. Ultimately, they're increasing the synapses and neuroplasticity. Only difference is taking a long time. Again, that's a new understanding. So who knows how that's going to change as we know more about other drugs that come out. So another drug, just a quick dextromethorphan. This is another Me Too drug. Basically, it's a cough suppressant. It also binds to NMDA receptor using with bupropion to block the breakdown because dextromethorphan doesn't stick in your bloodstream for too long. It quickly metabolizes. So when you give with bupropion, it blocks the liver enzyme that breaks down the dextromethorphan. So dextromethorphan can stay longer in the bloodstream and then can reach the blood-brain barrier and get to the receptors where they need to be, NMDA. Again, the mechanistically the same thing, only difference is oral, and there are some differences. Most oral antidepressant trials, you take 4 to 6 weeks, but you can see in the data for dextromethorphan study, people were separated even a week or two later. So even the company didn't think they would separate that fast, so their outcome measures were more programmed for 4 weeks. So, but when you look at the data, people were separated from placebo within a week. So obviously, when you modulate NMDA receptor, effects are quick. That's bottom line, right? When you see the ketamine studies, you see the S-ketamine studies, and you see the dextromethorphan data. And we also understand there are 2 different mechanisms of efficacy of ketamine that will stick around, right? So some of them are immediate, some of them are long-term. So we were able to separate it out in the 2 different pathways, how the interneurons at the presynaptic level, interneurons at the postsynaptic level, possibly helping with the long-term potentiation of that effect. So now we understood how the glutamatergic signaling modifies the depression treatment, way more than what we knew 20 years ago. All right, so these are other drugs that are kind of in the research side. You can see the ketamine, R-ketamine, other isomer of ketamine, hydroxyketamine, both are AMPA and NMDA targeted. And there are S-methadone, which is isomer of methadone without opioid effect. That's also NMDA antagonist. Likewise, seltorexant is another orexin blocker, just like similar to other Rexant drugs like Belsomra, Divigo, QVivic. There are 3 other in the market, right? So the seltorexant is also being studied for depression because that one has indirect effect on stimulating biogenic amines by blocking orexin. And then psychedelics, we're going to talk a little bit towards the end, psilocybin, ayahuasca, nitrous oxide. These are all being studied for depression treatment. And the casabitant is the neurokinin receptor antagonist. This is another intracellular target, just like cestrin modulator, 5138 in also for targeting mTORC or mammalian target of rapamycin. So they're using different targets downstream, not instead of NMDA, you pick different targets along the cascade of events that happen all the way to BDNF. There are a variety of different points where you can target to ultimate result is to increase BDNF and vascular endothelial factor, thereby increasing neuroplasticity and neurogenesis. So there were a whole bunch in the studies. What about schizophrenia? Schizophrenia, we had the same concept. We've been, wedded to the want it or not on the biogenic amines, right? So either dopamine excess or low based on where you're talking about, first generation, second generation antipsychotics targeting. And also there was a theory always, a glutamate dysregulation also in schizophrenia, even though we didn't put too much emphasis on it. And there was some early studies on the glutamate, but even though we didn't get it anything out of the gate yet. So if you look at the timeline of schizophrenia drugs, it started with chlorpromazine, you can see first generation, and then second generation antipsychotics, long-acting injectables, we changed quite a bit. But if you look at it, all of them are revolving around what? Biogenic amines. until we had one drug that just came out of the market. It's called xanomeline. Everybody heard of that? That came just very recently, a few months ago, to the market. Xanomeline plus tropsim chloride. I'll show you a slide, a little bit more detail on it next. And before that, there are other group of compounds that came out called VMAT2 inhibitors. These are approved for treating tardive dyskinesia. One is valbenazine, other one is deutetrabenazine. There is few differences between the compounds. I know this is probably not for this topic, but both are used by blocking VMAT2. VMAT2 is a vesicular monoamine transporter that kind of transports the biogenic amines in the presynaptic terminal. For example, if you look at it here, you see that this is where the dopamine gets synthesized, and then they get packaged into vesicles. And then when the signal comes, it comes down to the synapse. So when you use VMAT2 inhibitors, they block this step, so you have a less dopamine is stored. So when you have a signal comes, you have a less of dopamine available for activity. So thereby helping with the tardive dyskinesia. Tardive dyskinesia is a condition where you have hyperdopaminergic state. Even though you use antipsychotics, your body kind of try to compensate by upregulating dopamine receptors and also making receptors more sensitive. So your body is countering your dopamine blockade, so thereby creating a hyperdopaminergic state. So you can't really fix it by adjusting antipsychotic dose because you already blocked everything you have, right? So only way you can do is you can block dopamine upstream in the presynaptic level, thereby reducing dopaminergic tone. Interesting concept. Believe it or not, all these drugs were approved at one point for antipsychotics. Both tetrabenazine, all these were used along with reserpine as antipsychotics in 50s. Now they got repurposed as treating tardive dyskinesia, which is an important side effect that comes from antipsychotic use. See how we're coming in full circle? And this is the one that came in a few months ago, xanomeline and tropsim. This works by working on a muscarinic receptors. It agonist of acetylcholine, right? So there is a reciprocal inhibition between acetylcholine and dopamine, right? So that's why we use anticholinergics to help with side effects from antipsychotics. So thereby we increase the dopaminergic activity by blocking acetylcholine. So you take the same concept a different way, opposite side. How about if we increase the acetylcholine activity, thereby decrease the dopamine activity, right? So you don't have to use the dopamine blockers to treat psychosis, so you can avoid all the side effects that you get from antipsychotics because it doesn't bind to any dopamine receptors. Let's see how this fares. It's out, it's approved, and it's available in the market to treat schizophrenia. And these are other drugs that are in the research side. Ulotaront as a TAR1 agonist. TAR1 is a trace amine receptor, which is intracellular receptor. It has effect on the dopamine. When you stimulate TAR, then it would block the dopamine. So it controls or modulates biogenic amine release. So that's how it's supposed to work. Even though none of them are out there yet, so emaclidine, ulotaront, and ralmitaront, and lovadexitat, Nabin, and roluperidone, these are all being studied as an antipsychotics. Ulotaront, we thought ulotaront was going to be approved even before Cobenfy, but 2 failed phase 3 trials kind of put it off the market for right now. So they're still studying and doing more studies to see if it's effective in treating psychotic symptoms. And other drugs in development for other conditions with the different mechanisms. One of them very interesting with the troriluzole, which is a variant of riluzole, which is used for ALS. And this is used by a company for OCD treatment. Even though it failed in treating anxiety, GAD treatment, and it's failed in Alzheimer's or spinocerebellar ataxia. They've been trying, all these compounds because all these mechanisms are so common. Some of the degenerative neurological disorders and the psychiatric disorders. So that's why you see a lot of overlap of these drugs being studied for both neurological disorders and also for psychiatric disorders at the same time. And then you have a fasedienol, which is being studied for social anxiety disorder. Don't know, maybe another year or so, if phase 3 trials are successful, it may come out as an indication for social anxiety disorder. It's a nasal spray. Interestingly, it's supposed to activate some of the chemosensory neurons, thereby desensitizing limbic system activation, thereby helping you with the social anxiety symptoms. Interesting concept, right? And there is a quick snap on Alzheimer's. We always know Alzheimer's is one of the biggest ones on the dementias, right? 60 to 70% of all dementias, we know that. Pathophysiology always been a degenerative theory, right? Dying of cholinergic neurons and replaced by beta amyloid plaques or tangles, right? Plaques and tangles replace the dying neurons, thereby progressing dementia. So there are a lot of risk factors, genetic predispositions for Alzheimer's. We're not going to get into all that. So I want to show you about the drugs being developed and the concept, how it came out recently. So if you look at because our topic is mostly focused on the drug development, if you look at it, if you see a lot of the early Alzheimer's medications were focused on acetylcholinesterase. By inhibiting acetylcholinesterase, you're enhancing the cholinergic activity, thereby you possibly helping them because they're having a degeneration of those neurons. And except NMDA antagonist over here, it's called memantine or Namenda. That's the only one that's variant. That's a kind of oddball there, right? Everything else is targeting acetylcholinesterase, but this one is targeting NMDA. That's why this was studied for depression. You remember ketamine, S-ketamine were also NMDA antagonists. And riluzole was also, ALS drug was also NMDA. But those two drugs failed in a clinical trials for whatever reason. And the ketamine, that was the first one that came out, S-ketamine. And another interesting concept is you see the last 3 of them in the list. Those are called monoclonal antibodies. That's a completely new concept in treating dementias. All this time we were doing is medicine that targeting acetylcholinesterase, thereby enhancing the acetylcholine activity. But here, people thought, why wait until people develop dementia? Why not we be proactive and preventive? When people have what we call it mild cognitive impairment, that means they don't have even clinical dementia symptoms yet, but they have plaques and tangles. So we know that these two are precursors for developing dementia later in life. What if we charge up and start breaking down those plaques right away, thereby maybe we can slow down in development of dementia? That's a completely new concept, right? Some of you might have heard of monoclonal antibodies, kind of revolutionizing the treatment in oncology, right? All autoimmune diseases, even infectious diseases, and a lot of different types of cancers, monoclonal antibodies has been the forefront, right? So in psychiatry, this is the first time we had monoclonal antibodies approved for treating dementia. Again, all these are targeting the beta amyloid plaques. They break down the plaques. But the downside is when you break down the plaques, there is a consequence, right? There could be a microhemorrhages that can happen in the brain. So you have to have a MRI in the beginning of the infusion. Some of them are IV, and all of them are IV infusions. So you have to get a SPECT in between or PET scan to follow them during the treatment. And also you have a follow-up MRIs to monitor for any of the hemorrhages that's happening when they try to break down the plaques. But right now, it's like the judgment is out, so we don't know for sure. The risk-benefit ratio is completely in favor of treating. But there is a lot of controversy when the first monoclonal antibody got approved, Aduhelm, and the company had to withdraw that from the market because of a lot of concern about side effects. And then 2 more approved. After that, those 2 are available in the market right now. So under very strict conditions, usually drugs are administered in the neurologist's office or the psychiatrist's office. have to monitor very closely for hemorrhages or strokes or TIAs. So that's why you have to, again, these are the patients we're trying to treat. They don't even have a dementia symptoms. So the risks are very real. So that's why people have to make their own judgment whether it's really worth it. All right, so I'm going to take you a little bit of more recent stuff, what's happening. And these are the pictures when we ask people when they get a psychedelics, how we felt for them. These are the real drawings the people who were experiencing the psychedelics drew. And this is another one. So psychedelics came to the forefront only in the last 10 years. This was just like ketamine. We were very interested in developing psychedelics for different treatments. I'll take you to the history, but we abandoned for 30 plus years. And then after the ketamine, they opened the Pandora box. Ketamine is a kind of psychedelic. It's called dissociative psychedelic. It's not a classic psychedelic. But once the ketamine and esketamine approved, and people started looking at why not we go for other classic psychedelics? If just the miscellaneous psychedelic work this good, what if this real psychedelics will do, right? So that's where we are. So I'm going to walk you through 4 important psychedelics that are being studied. There are several, mescaline and other things I did not include, but the psilocybin is definitely in the forefront. It's been studied for anxiety, depression, PTSD, LSD being studied for anxiety, depression, MDMA mainly studied for PTSD patients, and DMT is also depression, PTSD. And there's a lot of researchers' dollars are spent, almost 70–80% of all psychiatric research dollars are spent either ketamine or psychedelic research. So all other non-ketamine, non-psychedelic is only accounting for 20% of research dollars. Can you imagine how much is being spent to find something out of the psychedelics? So I guess at least if it's that much research going on and that much hype or promise or whatever you think is happening, I think at least we need to be aware of a little bit of basics of some of the psychedelics that are being studied. So at least you know what to look for, right? So let's talk a little bit about psilocybin. Psilocybin is a prodrug. It's used for a number of years and centuries, even going back to 7000 BC. It's mostly used as entheogen. That means it's a substance that's used in religious ceremonies where it gives you additional consciousness. You get more spiritual connection in the ceremonies. That's what is used in South America, in a lot of Asian countries. It's used for that purpose. And it's a hallucinogen, right? It gives euphoria, and it kind of says some alterations of the time, just with the perception of time sense, just like a dissociation for ketamine. And there is another concept I want to just introduce to you if you're a resident. There was a theory, a whole lot of talk about functional neurological networks. It's called DMN, if you haven't heard of that, default mode network, versus TMN, or theory of mind network. DMN is the default by self-explanatory. That's how your brain circuits are at default. That means you are looking inward, you're looking at monitoring yourself, self-reflecting, and that stuff. And then when something changes, you go into the TMN network, which means you're looking at the surroundings, you're trying to make connections, you're trying to reacting and responding to surroundings. So why is it important is because there is a theory about how psilocybin works. That's why we need to have that background. It is primarily 5-HT2A. It's a serotonin agonist. Think about it. This is a biogenic amine again, guys, right? We went in a full circle. We started out biogenic amines, and we went to glutamate, we went to all other stuff, and then we are back to where? Biogenic amine. So this is targeting serotonin, right? And this works possibly, they think, they're going to temporarily deactivate DMN, which is a default network, and possibly enhance TMN. When DMN is active, so you're more introvert. When you have a TMN, you're more extrovert. So by decreasing the activity of DMN, maybe that will help with some of the self-image issues or some self-rumination about the negative thoughts, negative thinking. That's common in the depression. And that's, again, that's the proposed mechanism. Of course, bad trips happen, so it's not all hunky-dory, right, with psilocybin. It's studied in 60s. Actually, Harvard published studies in personality disorders in 60s. And that was abandoned, like I said, for decades, until 2018, FDA designated as a breakthrough therapy and allowed the research to go on. And then that's when it started out again in 2000s, I think it got more prominent. I think there are several active studies going on with the psilocybin, but a lot of studies are using a concept of psilocybin-assisted therapy instead of straight psilocybin. I don't know if it's a good or bad. That may work against ultimate outcome, in my opinion, but that's what we have. A lot of research studies are using psilocybin-assisted therapy. That means you have a therapist sitting with them for 6 to 8 hours when they're exposed to the drug, and then, of course, measure the depressive symptoms beginning at the end. But now you combine the therapy and the drug, it's hard to separate what is more effective here. Is it therapy being the primary treatment modality or the psilocybin being the primary modality? So that kind of becomes murky. I'll show you why it became a factor with MDMA. And there was one study published using 25 milligrams of psilocybin. It's a randomized controlled trial in 23. It's a positive trial, and effects lasted for weeks and months. And several phase 2 studies were showing 1 or 2 doses of psilocybin having a lasting effects for months. So we are seeing something that's even bigger than what we've seen with the ketamine or S-ketamine. We don't know if it's real or not. We don't know how long this is going to hold for phase 3 trials and all that we're going to scrutinize. LSD is other one that we need to be aware of. It's commonly described as acid. It's a lysergic acid. It is also serotonin agonist. It came from the same tryptamine derivative. And it's also psychedelic. It gives euphoria, hallucinations, out-of-body experiences, and all that. And it has some dopamine effect, but it works primarily by serotonin. Again, it's a biogenic amine, right? And the studies were published for schizophrenia in 1950s, believe it or not, LSD. But research and science didn't take off in 60s and 70s and LSD, but partygoers and the raves, and they're the ones who took it to extreme lengths, and then that gave a bad press, and so then it's abandoned by a scientific community for decades. And then until 2001, DEA looked at some of the earlier studies and then declared no use. And then in 2020, a meta-analysis came out that showed significant reduction of symptoms of alcoholism. Again, this is a highly addictive drugs, and then it's showing, some efficacy in treating substance use disorders. I guess there is a huge promise because a lot of psychedelics are increasing neuroplasticity and neurogenesis, either directly or using therapy with the psychedelics. We don't know for sure. We're still figuring out how much credit we should give to therapy, how much credit we should give to the compound. And other one is a Molly. You probably heard of that. It's a MDMA. This is a different kind of psychedelic. All other psychedelics are targeting serotonin or biogenic amine. This is a stimulant. This is not a serotonergic, but it's a dopaminergic. Still biogenic amine, but it's not a serotonin biogenic amine. It's mostly targeting dopamine, right? It's a methamphetamine. So you know what methamphetamine is. So it's mainly dopamine release and dopamine reuptake inhibition, enhances the dopamine activity. This was synthesized in 1920. It has been in our interest for a long, long time, and it's used for psychotherapy to facilitate. And it gives the euphoria, the same kind of hallucinations, but different quality than other serotonergic psychedelics. And believe it or not, MDMA is an approved drug in Australia for PTSD patients. Can be prescribed only by a psychiatrist. And even in Canada, it can be prescribed, but it's a limited distribution by specifically trained people, just like in Australia, but it can be acquired legally. in Canada as well. So there is a thought about facilitating PTSD. So this may be the drug that help you in connecting with people better. That's what people say. That's why empathogen, that means it increases your empathy. And entactogen means it increases your openness to communicate with people in the group. And that is so critical for people who have PTSD and how much benefit they can get from PTSD groups. So that is the proposed benefit that's kind of advertised. And the MDMA research was in a 2023, very active research, phase 3 trial. It was a successful trial. It separated from placebo and is published. And the FDA panel, 9-1 rejected. This is almost unheard of because a lot of times the FDA panel go by the data. This is the one time they didn't go by the data. 9 out of 1 people said, no, we're not approving MDMA, we don't recommend it. They have a lot of concerns about possible abuse potential, and also the same thing like I raised earlier, they use the same concept as MDMA-assisted therapy as a treatment modality, not just MDMA straight out as comparing with placebo with the drug. So then they said, how can we separate? Is it a therapy is the one we are approving, or is that the drug we are approving? Where is the difference? Where is individual credit? So that's one of the confusion that caused actually sync the drug, and FDA ultimately rejected the trial. You probably heard of a lot of protests among the PTSD advocates and all the advocacy organizations saying there was so much either expectation that this is going to be approved, just like a ketamine or esketamine were. So when this wasn't approved, there was a lot of protests and resistance from the advocacy organizations. And I'm sure it's not done, it's not over, it's going to come back. Maybe they might refine the studies, how they do it, how they compare with placebo. That's why people are rethinking. After all, this whole idea of psychedelic-assisted therapy as a treatment modality is not a good thing, at least for the research purpose. In the research, you need to really prove the drug, not the therapy, right? You can use the therapy as a modality to augment your medication treatments later on, just like we do for any other psychiatric condition, but not for research. None of the research studies would involve therapy as a part of the effect of the drug. So this is the last one. We're going to talk about the said promise for psychedelics. So this is also a serotonergic target, another biogenic amine, right? This is derived from the tryptamine again. And the similar experience, people have euphoria, hallucinations. Interesting thing is, DMT is psychedelic, but it doesn't last in the bloodstream for too long. So if you consume by mouth, it won't last. It has to be sprayed or it has to be injected. So thereby people are coming up with ideas how to make it last. So this is not we came up with. People came up 10,000 years ago from caveman days. So how they combined is 2 different plant products. One plant products, here you have these 2 plants have a DMT, mimosa and diplopteris, and then other plant group has MAO inhibitor. This is called harmaline. When you combine these 2 plant products, the MAO inhibitor will block the breakdown of the DMT, thereby prolonging the DMT in the bloodstream for a very long time, so it can cross the blood-brain barrier and cause all the psychedelic effects. So you're bypassing the infusion need for taking it. So that's how people kind of came up with it years and years ago. And this is the last one I'll show, and then shut up. Here, this is ayahuasca. If you people never heard of what ayahuasca means, like I showed you 2 chemicals earlier, 2 plant products. One is harmaline containing plant, and then DMT containing plant. And there is a specific method you can look up and say each country, each tribe, and each location has a different recipe how they make ayahuasca. So the concentration may be different, proportions may be different, concept is the same. Combine them to prolong the DMT. So there are several ayahuasca clinics along the California-Mexico border. People go there to experience the ayahuasca. And interestingly, there was a study came out not too long ago looking at the tribes who were drinking ayahuasca every single day. Apparently, they have a less addiction and no cravings for any other drugs. And they imaged their brains, and they didn't have any abnormalities. So you figure, so is it beneficial, or is it something they got something from ayahuasca or not? But just like a ketamine, and when it came out, how much hype was there in the media, people were craving for something to work in treatment-resistant depression, people are now going for something psychedelic experience. So this is one of the closest you can get, and they're available along different countries, even closest in Mexican border. All right. So in a sense, we talked about biogenic amines, and we kind of stuck with them for a long, long time. And we thought we almost lost them because we found a better ways to treat depression and other psychiatric conditions. And we also found other ways to treat using glutamate as a target, neuroactive steroids as a target, and GABA as a target. We looked at other things. And the ketamine revolutionized the treatment because of this fast action and also treating treatment-resistant depression. And then we came to the psychedelics. We came in full circle. We thought we're done with biogenic amines. Then now we're all over on biogenic amines. So now people are thinking it may be not just because biogenic amines, because how we treat it is important. Some of them are work differently than what we know at this point, why psychedelics works as fast. All right, so I'll leave it at that, and thank you so much.
Thanks, Dr. Katragadda. Joseph here. I agree, that was a great presentation. We've been taught, again, the same theory you spoke about a little bit as BDNF as a common final pathway for depression, and how things that seem to increase that earlier on, like ketamine, Auvelity, tend to improve symptoms of depression faster. Do you foresee a movement to where we can produce a synthetic BDNF or anything like that to specifically target that better?
So there are some studies. The question, everybody heard it, right? So is there a possibility of targeting BDNF? Why kind of go around and cut the chase and go to the last target and maybe make it more effective? Yes, that's exactly what some people are thinking, and they're picking up different points in that pathway all the way to BDNF. There were few studies that were done in phase 1, phase 2 level targeting BDNF. We haven't mastered it, and we haven't been able to show the robust response. So now people are thinking sometimes not just having a BDNF, but the whole cascade may be important. So here we are testing a lot of things, right? So maybe people thinking now the ketamine, S-ketamine are effective not just because BDNF went up. All the other steps that happen that lead to the high BDNF is very important. So the AMPA activation and all the protein kinase stimulation all along the intracellular proteins, mTOR pathway, and then you have the BDNF increase. So there is a debate right now going on and see if it's technologically we are not there yet, basically.
Okay, I think that wraps it up for this afternoon. Thank you, everybody. Have a great day.